Good morning, everyone. Today, our group will present our project on factors contributing to diabetes under the course Data Analytics for Digital Community. Our team members are Hikmatul Husna, Yusmawati Nur Farahin, Nur Iwani, and myself, Indusha. Diabetes is a major global health concern with millions affected worldwide. Early detection is crucial to prevent complications. Many in the community are unaware of diabetes risk due to limited screening access. Our goal is to empower individuals through a digital risk assessment tool.
My name is Nur Farahin. So next, I'm going to talk about problem identification and dataset selection. The rising prevalence of diabetes, particularly in underserved communities, highlight the urgent needs for proactive healthcare strategies. Current methods often fail to utilize available health data for early detection. To address this, the PIMA Indian Diabetes Dataset was selected due to its rich clinical variable and sustainability for predictive analysis. This dataset enables identification of key risk factors, supporting data-driven intervention to reduce diabetes incidence and improve public health outcomes. Next, community-based problem statement. First, increasing diabetes cases. Rapid rise in diabetic prevalence, especially in Malaysian communities. This can lead to a long-term health complication and higher healthcare costs. Second, lack of early detection. Most interventions are reactive but not preventive, and also have low awareness and screening, especially in underserved areas. The last one is underutilized health data. Valuable patient data exists, but it isn't fully used, and data analytics can help identify high-risk individuals early. Next is dataset description and justification. Dataset overview. We choose PIMA Indians Diabetes Dataset, which, which consists female patient aged 21 and above with 8 clinical features.
So on
The
exploration data
target
analysis, we will talk
variable
about
is
data
either
summary,
presence
then data
or
cleaning,
absence
graph
of
analysis,
diabetes.
and the summary of
The
the
key
one with
features
dataset description.
variables
So we use
include
the
glucose,
PIMA Indian
BMI,
dataset, which contains
age, insulin, blood
768
pressure,
records
and
with 8
etc.,
clinical
which
features
is suitable
like
for
glucose,
analyzing
BMI, and age. So
diabetes risk
before getting
factor.
with our analysis, we clean the
Why
dataset
this
first. So
dataset
we
is
identify several
important?
values that were
It's
biologically
widely
invalid,
used,
like glucose or
reliable, and well
BMI, which equals
structured.
to 0,
It
which don't
enables
make sense in
predictive
real life.
modeling
So we
and
replaced
early
those
risk
with missing values and
identification,
handled them appropriately.
and
We also
support
group some
data-driven
continuous features
strategies
like
for
age and BMI
prevention
into
in
meaningful
communities.
categories to
On
make
this
trends
part,
easier to see in our graph.
on glucose distribution, so this bar chart shows that glucose levels among the people with and without diabetes lah. So we found that most diabetic individuals had glucose level above the 120 milligram per day, while non-diabetics were mostly in the 80 to 108, 119 range. So this makes sense medically.
Next, we look
since
at
high glucose
BMI
is
or
the
body mass
main
index.
diagnostic
As
feature
this
for
line
diabetes.
graph shows, the percentage of diabetic individuals increases as BMI goes up lah. So this supports the links between obesity and diabetes, where excess weight contributes to
on
insulin
this slide
resistance.
about age and diabetes. So age is also another important factor for us to indicate diabetes. So we observe that most diabetic individuals are aged between 40 to 60, while non-diabetics are mostly under 40. This highlights the importance of screening people once they reach middle age. So we found that the pregnancy people tend to have diabetic itulah because this might due to the risk like gestational diabetes during pregnancy, which increases the chance of blood pressure levels in individuals with high blood pressure above 90 millimeter mercury had a noticeably higher chance of having diabetes. So this supports what we know in healthcare, that
diabetes and hypertension often occurs together due to the shared risk factors like
this
obesity
top
and
plot shows
the diabetes pedigree function, which represents the family history lah. So the people with diabetes often had higher genetic risk score, which confirms that family history is also a strong predictor lah, especially when combined with high
to summarize
BMI, age,
our
or exploratory data analysis findings. So the strongest risk factors for diabetes in this dataset are high glucose, high BMI, and age of over 40. So family history and high blood pressure also play an important role in it's also an indicator for diabetes lah. And then even pregnancies shows a link highlighting how multiple factors contribute to diabetes risk. So these insights help us select the best features for our machine learning models lah.
Next, we are used two types of machine learning. First, supervised learning, where the model learns from data that include the correct answer. In this case, the outcome column which tells us if a person is diabetic or not. We use two models, logistic regression and random forest. Second, we also explore unsupervised learning using k-means clustering, where there is no label, and the model tries to group patients based on similar health feature. Next, I would like to explain the confusion matrix. In this project, the model was trained to predict whether a person is diabetic or non-diabetic, which we refer to as a classification problem. The model used in logistic regression. This matrix shows how well the model performed on the testing data. It correctly predicted 79 non-diabetic patients. This is shown in the top left yellow box. It also correctly predicted 37 diabetic patients in the bottom right blue box. However, the model made some mistake. It gave 20 false positive that are patients predicted as diabetic, but actually they are not, and 18 false negative. These are actually the actual diabetic patient, but the model predicted them as non-diabetic. Although there are some errors, the results still show a reasonable level of accuracy and performance, especially for a basic model. Now let's look at the ROC curve. This graph helps us understand how well the logistic regression model can tell the difference between diabetic and non-diabetic patients. The curve plot the true positive rate against the false positive rate. The more the curve bends toward the top left corner, the better the model is performing. In this case, the model AUC score is 0.81, which is considered good. AUC stands for area under the curve. A value of 1 means perfect prediction, while 0.5 means random guessing. So, or 0.81 show the model is quite good at distinguishing between the two classes, diabetic and non-diabetic. This confirms that our model has strong predictive ability. This graph generated using the random forest model. The purpose of random forest model is to identify which features or health measurement are the most useful for predicting diabetes. This bar chart shows the important level of each feature. We can clearly see that glucose is the most important feature. It has the highest value, meaning it plays the biggest role in the predicting diabetes. After glucose, the next important factor of are BMI, which refer to body weight and age. This makes sense because high glucose level, higher BMI, and older age are all linked with a greater risk of diabetes. This information is useful because it helps doctors and researchers focus on the most critical health indicator when screening patients.
We also tested unsupervised learning using k-means clustering, just for exploratory analysis. The elbow method here helps identify the best number of clusters in our datasets. As you can see, the curve flattens around k equals 2, suggesting the data can be divided into two main groups, possibly diabetic and non-diabetic. But for this project, our main focus remains on supervised learning models like logistic regression because we have known target outcomes.
This table gives a clear comparison between supervised and unsupervised learning in machine learning. In supervised learning, the model is trained using data that already include levels, for example, the outcome column that tell us if a patient is diabetic or not. The main goal is to predict the level, like 0 for non-diabetic or 1 for diabetic. In this project, supervised learning model include logistic regression and random forest, and the graph we use are the confusion metric, ROC curve, and feature importance. On the other hand, unsupervised learning doesn't use any labels. The model tries to find pattern on its own. The main goal is to group the data, like separating patients based on similar health features, even without knowing if they are diabetic. For this, we use k-means clustering, and the graph used was the elbow method, which helped us choose the best number of clusters. In short, supervised learning predict known labels. Unsupervised learning group data both based on hidden patterns. This comparison helped to understand how both types of learning were used in the project. Now let's look at the discussion of prediction result from our machine learning project. Overall, the model performed well, showing potential for early diabetes screening and health monitoring. However, there is still room for improvement. In the future, the model could be further trained using more data, or we could try different algorithms to improve prediction accuracy even more.
For this project, we developed a simple and mobile-friendly web tool called the Community Diabetes Risk Screening Tools. This app allows users to check their diabetes risk by answering a few health questions like age, BMI, glucose, blood pressure, and family history. The goal is to support early detection, especially for unserved communities, through an accessible and easy-to-use platform. To design the prototype, we use VCD, which is an AI-powered tool that helps convert text into a real interface screens without coding. This has made it faster and easier for our team to create a mobile-friendly app, even without advanced design skills. For the prediction model, we use Python and scikit-learn because they provide reliable, interpretable machine learning results suitable for health screening tools. You can also watch the full demo video at the YouTube link provided.
As the conclusion, our project combines data, AI, community health to enable early diabetes risk detection, and supporting SDG Goal 3 for better well-being. Thank you for your attention. We welcome questions and any feedback.